Okay, chapter 53, last one, pain management, acute and chronic pain. Um, Here's your overview, the experience of pain, pain threshold, acute, chronic pain. What you need to know mostly is local pain. What causes local pain? It's neurokinin. A is the chemical responsible for the spread of local pain. Um, Unfortunately, we become the pain specialist a lot in primary care. Just remember, you always need to look into your Illinois drug monitoring. Not that I'm telling you that everybody who's in pain is a drug seeker, because I don't mean to say that, but you're going to get many patients who come in and somebody has given them 560 Norco and they're going to expect you to fill it as well. Just learn to say no, and it will alleviate a whole lot of problems for you. It may make people mad, and that's not really your problem. If you have somebody who needs to be taking way too many drugs, you need to refer them to pain, and then they need to figure out from there what they can do. Once again, medicine doesn't like this. We just like to treat the symptom. We never find out what the problem is, so that would be the important thing. People with back pain tend to get addicted to all kinds of things. I don't really understand the Vicodin and the Norco. It doesn't get to the layer near the spine that stops the pain, so there's really not much use in those things. So that's how those people end up on Tramadol and OxyContin and all kinds of things like that, because they do work a little bit better. Anyway, so this will be your very last section. Different areas of the brain are involved in different aspects of pain. So you have your reticular and your limbic systems in the brain that influence what? Does anybody remember that? About your reticular and your limbic system. I guess I should probably tell you the answer. But here we have your pain. So this is your pain experience. So different parts of the brain motivate that, right? So the reticular and the limbic system, that's the motivational aspects of pain. That's what that one does. So it's this one here. So you need to know that there's three major systems. Okay, and they always report their most severe pain, and remember their most severe pain. So you always need to ask your patients all of their pain sites. Like if you have somebody who comes in, and why do you need to do this? Because they always tend to report the most severe or important in their perception. So even today I had someone come in who was having terrible pain. It kind of sounds like he either has a fibromyalgia, but more of an RA picture, and his most severe pain was his feet, actually, which he also has a neuropathy. So they're always going to report, patients will always report the most severe and important to them of their pain. So I told you which chemical promotes the spread of local pain, and that would be neurokinin A. That was way at the top. How do narcotics act? I guess that's another thing that we need to talk about here. Let's see if we can get here. Okay, so we have opioids. So how do narcotics act? Well, we're not really talking about opioids just yet, but narcotics always, they attach to the receptors in the afferent neuron to inhibit the release of substance P. Oh, it is right here. So this is how narcotics, it is opiates as well. This is how they act, by attaching to the receptors that inhibit the release of substance P. Kind of just brings you back to your patho class a bit. So do you think age is a factor in different responses to pain? What are some age-related, what would age-related statements be? I mean, let me give you just an example. Everybody thinks that preterm babies or newborns don't have functional pain pathways, and that is very, very much not true. So babies that are born at 23 weeks definitely have a strong pain response. So that's an old myth that we used to believe. So that's an example of an age-related pain statement. that isn't true, that preterm and newborn infants do not have pain paths, because they do. You can have those kids screaming like crazy, whether there's noise coming out or not, and a lot of times there still is noise. So that's one of those things. I mean, older adults, they do not have a decrease in, they do have decrease in pain tolerance also. But looking at statements that aren't true, preterm and newborn infants, when somebody tells you they do not have pain pathways, they do. What do we know about acute pain? Referred pain is present in a distant site for the pain source and is based on activation of the same spinal segment as the actual pain site. So referred pain happens a lot. Hang on, let me find your referred pain. So referred pain, like I said, is present in the area removed or distance from its point of origin. So that's kind of like having a gallbladder attack where your hurts over your right shoulder, things like that. That would be an example of referred pain. And let's see, classes of drugs used to treat acute pain are NSAIDs. And why do we use NSAIDs? Because we know about acute pain, that inflammation is usually the cause for acute pain. So that is why we use NSAIDs for those. And remember, there's all different types of pain. So why do we use opiates to treat moderate and severe pain? Opiates are used always to treat severe and moderate pain. They're capable of triggering and acting on several receptor sites. So they're good for visceral pain, they're good for referred pain, they're good for all types of pain, but it has to be severe. That's when they're best, they work the best. Usually, they are all scheduled and require a DEA and a hard prescription. They stimulate many receptors for the control of pain. Most of the opiates have adverse effects related to mu receptor stimulation. And what do we do to reverse opiate adverse reactions? Is naloxone or Narcan. So that will reverse our effect if we give somebody too much morphine or fentanyl. Back to the intervention of pain, I think we've heard of the RICE acronym. If interventions to resolve pain using RICE are not sufficient, we always give pain medications, right, based on the severity of pain. So what's the order in what we do with these pains? So we're always going to start with a non-opiate, then we're going to increase the dose of the non-opiate before we go to an opiate. So that's your best plan of attack. So you're going to just say give ibuprofen, and then if that's not working, you're going to increase that dose, and then you can go to an opiate. That's usually the plan of attack. You want to start small to biggest. A lot of times pain works itself out, or there's some healing if it's an inflammatory process. I'm not talking somebody who's in total chronic pain. So this is the best way to go with that non-opiate, increase the dose of the non-opiate and the opiate. So just kind of remember, you just don't jump to the big guns. I mean, sometimes you do have to. If you have somebody who comes in that's in severe sciatica sometimes, usually I'm a fan of the Toradol shot right there, the anti-inflammatory. So the cocktail pretty much can be, you can give the Toradol shot, you can send them home with some Flexeril, you can send them home with a little Norco. Be careful how much you give, and that's more for sleep. I don't know that it actually really helps all that much because there's no anti-inflammatory action to it whatsoever. The other thing too, if they're having some nerve pain, you can always give a small dose of Valium, and sometimes that works pretty well too to relax things and starts to work itself out if they haven't done some real damage to their back. So just kind of be careful what you prescribe, because I think we don't always know who or what we're dealing with as far as that goes. Somebody who can come in for a problem and end up being totally addictive. So something to take into consideration. The goal of treatment for all acute pain is the reduction or elimination of the pain with minimum adverse side effects, and that includes causing them to be dependent on the drugs. So you're just about done. Now we've gone through all this with the pain. You know about your neurokinin A, that's the chemical responsible for local pain. And we all know that we have to listen to pain is what people perceive it. These are your 3 types of pain. Okay? And then you need to know that. Pain threshold and tolerance. The anatomy is on the afferent pathways. You need to know that. And endorphins, or opioid agonists, and where they attach to the afferent neuron to inhibit the release of substance P. Pediatric pain. Babies have functional pain by 24 weeks gestation. So just read over this and make sure you know. You may have to argue that point someday. Pain assessment in kids. This is all great information. Aging and pain. They have an increase in pain threshold. Many of them have neuropathies. Lots of older people are on Neurontin. They have a decrease in pain tolerance. And drugs, alteration in the metabolism of drugs. Definitely be careful with the elders in what you're doing as far as pain meds. I actually recently gave somebody a 25 microgram fentanyl patch, 25 mics an hour, and you replace them every 72 hours. This lady has a C7 fracture, and she was totally out of it with my lovely fentanyl patch. I did have the option of starting with 12.5. I just felt so bad. She was in such horrific pain and nothing was working. I gave her the 25. Elders are almost like kids. Less is more. I mean, they do not react well to pain meds whatsoever. I've had little old ladies seeing bugs climbing on the wall from 1.5, 325 Norco. So just be super careful. Less is more. You can always go up. And sometimes it seems like nothing works. Okay, so just know your difference between somatic, visceral, and referred. And what works for somatic is your acetaminophen, corticosteroids. Okay, visceral, just what you're going to use. COX-2 inhibitors are big now. And we talked about your morphine and your opiates. And I think we're pretty much good. But once again, make sure you utilize that Illinois prescriber, the Illinois monitoring website whenever you have somebody come in your office. If you're printing out a script, you need to take the time to look at that. Because if you're writing for 120 Norco and John Doe just filled 200 Norco from the guy down the street, you want to rip up your script and send them back to the guy down the street. Happens every day, all the time. It's just not a good thing, something you want to be involved in. Neuropathic pain is another one. Just know about it. And Neurontin or gabapentin is the drug of choice. Cymbalta, let's talk about Cymbalta. So that's an SNRI. Cymbalta is a great drug, especially for an elder who's having a lot of pain. You start it at 30 milligrams, and you can go up within the week to 60 milligrams daily. And what it does is it has a tremendous effect on pain. It's a great drug for that. So it has the twofold action of antidepressant and gets rid of a lot of their pain. So that's a drug I use a lot with the elders. And pretty much, I think we're good. So congratulations and good luck, because you are just about done with advanced pharmacology.